Hi, people. So, today I'll be recording one of the most important presentations ever, and that is trauma, dental traumatology. It overlaps in specialist fields of pediatric dentistry, endodontics, oral maxillofacial surgery, prosthodontics. But even if you're not a specialist and you are a general dentist, I'm sure you will 100% encounter dental trauma cases. Trauma are basically unintentional accidents which happen on the soft and the hard tissues of the mouth. Okay. A lot of things come into maxillofacial surgeries when big structures are involved, but when it's just the tooth getting fractured or a part of the alveolar bone, and the tooth also because it's composed of many different layers like enamel, dentin, pulp, and there are two different varieties of the teeth, primary and permanent, and the kind of injuries that happen, the dentist becomes the main person to whom the patients would come. And avulsion, that is called as X articulation, is the only dental emergencies where even if you are at home and a patient calls, you have to rush, because time is of the important essence. And the age of the patient and the amount of the time the tooth is left outside the mouth, because heavily it's going to influence the prognosis. Trauma is one of my favorite subjects also, because for some reason it kind of is an emergency response. There is an adrenaline rush because you have to act fast and you have to act precisely and you have to calm the patient, you have to assess many other things. I actually feel like a proper surgical doctor when I'm treating trauma cases. For some reason, this is my favorite topic, and understanding this is going to not only help you solve all the questions correctly of the ADC exam or any other exam for that matter, but it's going to enable you and give a confidence of managing the trauma cases very precisely in a very efficient and a confident, calm manner. Because when a traumatic case comes, especially in children, uh, the child is terrified, the parents are terrified. So the only person who can emit the calmness is you. And you can do that if you yourself are confident of managing the case. I've had so far at least 15 to 20 evulsion cases in my career, and the parents have been traumatized so badly. Oh, the child's tooth has come out and it's a permanent tooth. Okay, primary evulsions, nobody cares that much, it's fine, you can easily calm the patient. But a permanent evulsion is very traumatic psychologically and otherwise also. So you have to calm the parents, you have to calm the patients, and the prognosis is not certain, so you have to be confident upon what you're explaining, how to do it. And I have seen at least 80% of my Vulcan cases going more than 8 to 10 years so far. And many of them have crossed 5-year mark and the tooth is still there. Some of them getting ankylosed, some of them being nice. It gives you such a good sense because the way you handled the tooth, the way you handle the parents, and parents are so grateful to you, and you see that happy smile of the child, you truly feel that all your studies have been justified. So, anyways, let's not go much into detail and let's focus on this topic. See, trauma is a topic, the gold standard book is Anderson. There are many people who have classified dental trauma. As a clinician, if I talk to you, I would be mostly taking the Ellis and Davis classification because that's the most broken down, precise classification. But there are more than 20 different classifications of trauma. And one of the gold standards is of Anderson, and I'm going to go through that in this presentation as well. But mostly I'll be focusing on the Ellis and Davis classification. See, Anderson's classification is applicable both on primary and permanent teeth. Ellis and Davies classification is just for the permanent teeth. But the same classification is given for primary teeth, but that is not of Ellis and Davies, and that is Garcia Godoy classification. So if I tell you I'm talking about a class 2 fracture in a primary tooth, it is not the Ellis and Davis classification, it's Garcia-Godoy classification. So remember that. In Ellis and Davis, the primary teeth classification falls under class 9. Okay. But here in this presentation, I'll go step by step. I'm just giving you a brief intro. So go through this presentation, pause it, revise it, read more about it if confused. I'm trying to make it as precise from the exam point of view and from a good clinician point of view. I shall also be showing one or two of my own cases which I have done for a better understanding. The presentations that I'm showing to you are not my presentations. I have taken three different presentations from three different postgraduate students, and I'm going to shuffle them and share it to you because it was impossible for me to make a presentation on such a short notice, and I have been getting many requests to make a video on trauma. So I'm thankful to all these postgraduate students who have given share their presentations with me. There are certain modifications which I would be saying, so just don't blindly follow what is written because some of these presentations are following the old guidelines. So I'll be telling you what is the current one, which is liable to change if you're watching this video after 5 years from now on, if a new guideline comes. So whatever I'm saying is as per 2023 guidelines. Understood? So let's start. So what is trauma? See, trauma is basically an unintentional accident which has caused some form of injury. Now that injury is going to depend upon the impact, and the main questions of yours to the patient should be how it happened, where it happened, and when it happened. How will give you an idea of how forceful it was, or was the child safe, it was an accidental one, or you think there is some foul play, it will give you like an idea. Where it happened will give you an idea whether you would have to ask the parents to take the child for a tetanus injection. Was it in a clean area, was it a heavily infected area, stuff like that. When it happened would give you an idea of the timeline, because in complicated fractures, complication means pulp is involved or a root is fractured, or the tooth has come out of the mouth, that is avulsion. The time becomes of very much essence because it changes your treatment plan and it changes the prognosis also of the tooth. So these three questions are first. Second important question would be, when a patient comes to you, you should be asking, is the neck of the child fine? Is the child unconscious? I mean, or did he become unconscious when the injury happened? Was there vomiting involved? Because in any trauma, the life of the patient is way more important than the dentoalveolar stuff. So once you have ruled all these things out, then you focus on the injury side. When a patient comes to you telling, doctor, I think I've chipped my tooth, you will not directly jump on examining the tooth. You would ask him these questions first. Even in your ADC exam, if the question mentions a father came with the child and the child had fractured, it was a class 2 fracture, and the options are given, do composite, do GIC, do blah blah blah. And one of the options would be, you will ask the child if he's fine and did he have any other injuries or was he unconscious. This would be your answer of choice. Do you understand? You will not jump on to say, no, no, restore it by composite. That would be wrong, unless the question mentions that the child is fine otherwise, and now what you would do for this tooth. Then you can choose whatever the options for the tooth. But if you directly jump onto the treatment without asking these questions, ADC or any other exam should fail you, because then you're not doing your job properly as a clinician. I hope you're getting my point. Okay, let's go to the next slide. So, who are more likely to get injury of the teeth? See, children who don't have any coordination. That would be in the age of 2 to 3. Like, they just want to jump and not be bothered about how their body is falling. That is basically the toddlers. The second injury most often is between the age of 7 to 10 years, when again the child is competent enough to participate in sports, and hence you get the injury. I myself have an injury on my central incisor. I have a class 2 fracture at the age of 10. I was running behind my brother and I slipped and fell and blamed him for it. So, anyways, protruded teeth, any medical ailments like in epileptic patients, cerebral palsy patients, they're more likely to have such fractures. And if a child comes to you with such kind of a fracture, it's your responsibility to inform the parents to take care of all such things. Understood? Now, suppose a new child also came to you for examination and you find that the front teeth are way, way protruding, and so far he's not had any fracture by God's grace. Then you should also tell the parents at that time, you know what, there's protrusion of teeth, like the lip is incompetent, the teeth are protruding even at the rest position. The child is at an increased risk of having a trauma, especially the class 2 div 1 cases. There's literally 10% more risk of the child having a trauma and fracturing his teeth. So, to avoid that, get ortho treatment done or wear a mouth guard or do some other form of treatment to correct that. So, you should give this advice not only to those children who had a trauma, you should also give this advice to children who didn't have a trauma so far but are at an increased risk of having it. That would make you a better clinician because the parent has come to you for checkup and you should be saying all this thing to them. Now, I would like to go through the Anderson's classification first. So let me go there and then I'll come back to this presentation. This is Anderson's classification. Crown infraction. What is crown infraction? Infraction is an incomplete fracture or crack of the enamel without loss of the tooth substance. Gray's lines, you call it. You don't do anything for it, but sometimes they will gather a lot of stains. You can do, if you would like, a thin veneer or a laminate on the tooth, but nothing else apart from this. Then you have an uncomplicated crown fracture. This is Anderson's classification. Okay, we'll go to Ellison Davis classification and we'll talk about these things again in detail. But I'm giving you the gold standard of trauma classification. Uncomplicated. Uncomplicated means what? The pulp is not involved and the root is also not involved. So this is the most simplest kind of trauma and it's easily manageable and you are also happy and the patient is also very happy. Like I like such cases when they come instead of a complicated crown fractures, which are more difficult to manage and the prognosis is a little dicey. We see the prognosis is very nice. So this picture A is an uncomplicated crown fracture, the enamel and dentine fracture. What you do is you either cover with a GIC or after GIC you put a composite. Doesn't matter the root is complete or not complete. You just do the simple thing. Half an hour the case is finished and you go. Complicated crown fracture. Now, complicated crown fracture means what? The pulp is exposed. Now, here a lot of things is going to come into question. In my own pediatric dental exam, I had this question as the main essay. An 8-year-old girl comes to you with a class 3 Ellis fracture. It's 2 hours since she has come. What will you do? Long answer of 8 pages, like describing different scenarios. So anyways, a complicated crown fracture means what? The pulp is exposed. I will talk to you in detail about the various scenarios, how much it is exposed, what to do when it's a closed apex, what to do when it is not a closed apex, okay? So right now I'm just giving you the classification of it. Next is uncomplicated crown root fracture. See, the only place in the uncomplicated crown root fracture, which is like this, it's going below the gingiva in an oblique direction. You can save the tooth. You don't have to extract it because you can remove this fragment or you can reattach this fragment if it's come completely properly nicely. But if it was a vertical one, you will have to extract the tooth because it's impossible to attain a proper marginal seal below the gums near to the bone. In this area we can, but if this line was like extending right till here, then I would be extracting that tooth. So an oblique fracture just below the cervical margin is a savable tooth. So that's an uncomplicated crown root fracture because the pulp is not involved and it's not way too inside. It's still in the cervical portion of the root fracture. Then you have a complicated crown root fracture, that is the NMAS, that's the Ellis-Davis classification 8. So what is complicated? Half of the crown has just fractured and a part of it is inside the gum and the bone, and there is little bit of the bone fracture as well. This is a complicated crown root fracture. Now, depending on situation to situation, sometimes you have to extract the complete tooth, but sometimes you can save it. Okay. Root fractures. Now, root fractures can happen either in the apical third, in the middle third, or the cervical third. Depending where it has happened, the treatment will differ. I'm just giving you a brief. We'll talk about this again in detail when I'm talking about the Ellison-Davis classification. If it's just an apical fracture, this entire portion would be sturdy. It won't be movable. So in that scenario, you will just leave the tooth as it is. If it's a middle fracture, you will splint it. I will talk about the splints in the later part of the video. If it's a cervical fracture, we'll determine how much the tooth mobility is there and how much splinting is possible. The best prognosis of the tooth is when there is an apical fracture. This is still a doable fracture. You can still save the tooth. This becomes a little complicated. It may or may not be saved. So this is what a root fracture means. See, this is the drawback of Anderson's classification. Though when I say root fracture, you will instantly know there is a fracture in the root. But it has to be more precise. Like I should be able to tell you it is in zone 1, zone 2, zone 3. Like this is zone 1, this is zone 2, and this is zone 3. Where the fracture has happened, how much is it oblique, it is horizontal, how much the coronal fragment movement is present or not, all these things. Next is injuries to the periodontal tissue. Sometimes children, I mean, not children, I would say students, get confused with this, but it's really simple. What is concussion? Concussion is basically if you are walking and you bump your head. So there is a small bump on your head, but otherwise you're fine. That is concussion. So your tooth just had, your tooth basically got bumped into something. So it just got in a stage of shock basically for some time. It became a little wobbly, but not too much. But it's still in its place and there is no fracture of any sort. But somewhere some of the periodontal ligaments got injured and a little bleeding like this happened. That is called as a concussion. In 99% of cases, you don't do anything. You just leave it like that and ask the patients not to bite on anything heavy. Subluxation. Subluxation is a second step of concussion. The tooth bumped basically, and it also got loosened and a bit displaced. Displaced can be in the same direction, that is vertical, or it can be displaced in a labio or lingual direction. It won't be displaced mesial or distal because if it is displaced mesially or distally, that means some alveolar bone fracture has happened. So basically, there is abnormal loosening of the periodontal ligament and it has either extruded or it has moved a bit palatal or labial. In this scenario, depending how much of subluxation has happened, you will either reposition the tooth and splint it. I will talk about the duration of splinting and all in the Ellison-Davis classification. Or you can just leave it as it is, depending on which tooth it is, primary or permanent. Then you have intrusive luxation. So luxation can be divided into, three parts. Intrusive luxation means the tooth has fractured the apical portion of the alveolar bone. It's gone completely inside. Extrusive is means it's come out of its socket by at least 3 to 4 millimeters. Lateral is it's fractured one of the alveolar bones on the mesial and distal and it's like displaced. Lateral luxation mostly happens in children, but it can also happen in adults. Extrusive and intrusive can happen in either of the dentition. So this is how a lateral luxation is going to look like. This is an extrusive luxation. This is an intrusive luxation. Sometimes the tooth is intruded so much that the parent will come and say, Doctor, I can't find the tooth after trauma. I don't know where it fell. And you would see there is nothing in the gums here, it's just blank. But when you take an x-ray, you see the tooth is completely pushed inside. So don't just go on the patient's words. You have to take an x-ray first after the trauma. X articulation, that is the only dental emergency. It's a periodontal emergency. It actually falls under periodontology. It's the only periodontal emergency because the entire tooth has come out of its socket, and it becomes like a very emergency situation because the earlier you replant it, the better prognosis you have. Otherwise, the body starts treating this tooth after reimplanting it as a foreign object, and hence all the things happen to it afterwards. What are the things that can happen? They are ankylosis or external resorption or internal resorption or replacement resorption or inflammatory resorption, any of these things. We'll talk about it in detail. Supporting bone structures fractured. The tooth is fine, the alveolar bone has fractured. The entire segment of the alveolar bone would be movable. This becomes a complicated solution. So, as a general dentist, if you're not able to splint the alveolar bone, please refer to the oral maxillofacial surgeon. Fracture of the alveolar socket, we spoke about it. The entire segment, we spoke about it. Mandibular fractures, etc., etc. I won't go into much more detail. So this was the Anderson's classification. This was the gold standard of classifications, and I didn't want to jump directly on Ellis and Davis classification before giving due respect to this author. There are 4 volumes of this book, Anderson 1, 2, 3, 4, and it's a huge book, and it's a beautifully written book. If you ever get time in your life, please go to a library, open this book, read. We are blessed that we have the guidelines what to do in such cases. That author like found all these guidelines, made one, and done so much research so that we can easily practice in our clinics. So due respect to this author. I mean, I'm really grateful to him that I could find one of his books and read it. And my pediatric dentistry didn't have this book in my curriculum because we were focused more on the other parts of the pediatric dentistry. But in our library, we had this book, and I had the opportunity and the blessings to go and find it and read it. And I'm delighted to share that if you have time, all the oral surgeons who have read this book will know what I'm talking about. So, anyways, let's move on to the actual classification now, which we all mostly follow and discuss the term, and that is the Ellison-Davis classification. This is just a diagram. Trauma pathfinder, basically when a patient comes to you, you want to see it was a nice diagram, so I thought I will share it with you, that what has happened. It can be nothing, it can be crown fracture. You have to determine which type of trauma has happened, and accordingly you will be doing the treatment for the child. So let's go back to the Ellison Davis classification. I hope you're with me so far. Yes. So let's go to, I already discussed when the patient comes to you what you will do. Ellis class 1 fracture. What is Ellis class 1 fracture? This is a class 1 fracture where only the enamel is fractured. It can be just a chipping off of the tooth, it can be complete horizontal fracture, whatever. It's very, very easy to fix it. See, Ellison Davis, like I repeat, is for permanent teeth. I'm not talking about primary teeth right now. Primary teeth is Garcia Godoy classification. But meanwhile, while discussing Ellis and Davis classification, I will be talking about the primary so that I don't have to repeat everything again. So first, I'm talking about Ellis Davis, that is the permanent. If you find a fracture like this, you can either build it by a flowable composite or a proper composite. If it's even smaller, you can just reshape this area, you can recontour it. If it's in primary teeth, again do the same thing because you cannot leave a sharp edge, as the child may bite the lip and it's going to hurt a lot more. So this is the most simplest of fractures of the tooth. Class 1, only enamel fracture. Class 2 fracture. Now this is a class 2 fracture. Now, class 2 fractures can be of various types. The patient may come and he say, Doctor, I was playing or blah blah, and I fell and the part of the tooth fractured. If the person comes to you with a fragment of the chipped tooth, and you try and see and find that it's fitting really nicely, then you can reattach that fragment. Best, the child will have his own tooth back, and before you reattach the fragment, you will rehydrate the fragment a lot. Keep it in saline, then take it out, dry it, etch it, bond it, and done. Your job is done. But in case the child has not come with the fragment, then you would just reshape this area nicely and you do your composite filling. And if you feel the dentin is way too much exposed, then you can do IPC also, that is indirect pulp capping. You put calcium hydroxide, the light cure one, and then you put composite over it and you're sorted. That's a class 2 fracture, only enamel and dentine fracture. That's about it. See, this is the reattachment procedure. Another picture, part is fractured, the patient had a fragment, you clean the area, you etch bond, and you fix it like this. I've done a couple of these cases myself and beautiful result, it's very nice. So in case a patient calls you, doctor, my child just fell, he broke his tooth, tell them, find the fragment if you can and get it. And it gets done within half an hour. Class 3 fractures. Now this forms the essay questions in a lot of final exams. This will test your knowledge as a clinician. Now here listen to my explanation, don't read much. Class 3 fracture. When there is a class 3 fracture, the first thing that you should be thinking is what is the age of child. Class 3 fracture is fracture of the enamel dentine and there is pulp exposure. Now you have to filter out to reach the kind of treatment you're going to provide. So first question will be what is the age of the child? I'm talking about anterior teeth, okay? So the child is 7 years or 8 years and he's come to you with a pinpoint exposure of the pulp. Pinpoint, okay? You will ask the age of the child, the age is 7 or 8. Meaning what? The root is not complete. Means what? It's an immature apex. Do not do direct pulp capping, it's obsolete because according to Cameron, ADC, and other books and other guidelines, direct pulp capping will only be done if there was a rubber dam applied and there was a mechanical exposure of the pulp. Here the child had a fracture of the tooth and rubber dam was not in position at that time. Of course, nobody is going to roam around with rubber dam in their mouth. So some form of contamination has happened. And direct pulp capping is basically you're not touching the pulp and you're directly applying calcium hydroxide over it. But here some form of contamination has happened, be it the patient's own saliva. Okay. So what you will do is you will do a Civex pulpotomy. What is Civex pulpotomy? Civex pulpotomy is a superficial pulpotomy where you will give anesthesia to the child on that tooth. You will remove 2 to 3 mm of the pulp with a round burr. You're going to put a cotton and dry that area. You will put a calcium hydroxide hard setting paste over the pulp. And then you're going to put your GIC or composite over that. That is Civex pulpotomy. What is the aim of it? We want to preserve the rest of the pulp because the root is still not developed. I'm telling you this in case there is a pinpoint exposure. What is pinpoint? Less than 0.5 mm. Understood? But if the patient, according to the new guidelines, had more than zero point 0.5 but less than 2 mm of exposure, and he comes to you after 3 or 4 days, still you would go ahead and do Civex pulpotomy, that is superficial pulpotomy, because it's still less than 2 mm. Yes, it sounds strange because it's been more than 72 hours, but still the guideline says that you would go ahead. Even after a week, the patient comes to you, you will do a Civex pulpotomy. Of course, not more than 2 weeks, but at least within 2 weeks, also the patient comes to you with less than 2 mm of exposure. You will still go ahead and do Civex pulpotomy. If it's an immature apex, that it means the apex is not formed. Now, if the exposure is more than 2 mm, the patient comes to you immediately or anytime, but within 2 weeks. Then you're going to do a complete pulpotomy. What is a complete pulpotomy? You will again anesthetize the tooth and you would remove the pulp till the CEJ junction, that is cemento enamel junction. That is called as a complete pulpotomy. And then you will place calcium hydroxide or MTA or biodentine, and then you go about filling it with GIC or composite, whatever you like. That's called as a complete pulpotomy. Basically, you're doing an apexogenesis procedure. You are maintaining the vitality of the rest of the pulp, and you will have to keep on following up with the child. But if the patient come to you after a month, then you have to do a pulpectomy, not or rather an apexification procedure, which means you'll remove the pulp and you will either put calcium hydroxide to form a barrier, or you can do a single visit apexification procedure by putting mineral trioxide aggregate, that's MTA, right at the apex. That specialists do normally unless you are trained to do it, and you finish off the apexification procedure, because after a month definitely some form of infection and contamination of the entire pulp must have happened. Yeah, I believe you're sitting with a notebook and a pen and writing all this down. Okay, so this was about the immature apex. If you want to listen to me again, pause the video, rewind. I will not repeat. Mature apex. What is a mature apex? Means a closed apex. So again, say a 12-year-old child comes. There is a pinpoint exposure. When there is a pinpoint exposure and the child has come to you just now, you can still do, just now means within 24 hours, you can still do a civex pulpotomy. But if the exposure is more, then you have to do a complete pulpectomy. Then it's not going to be fruitful, because when there is more exposure, there is more contamination. So a pinpoint exposure in a 12-year-old child comes within 24 hours. You can still go ahead and do a civex pulpotomy. Not a complete pulpotomy, a cervix pulpotomy. But if the exposure is more, or the patient has come to you after 2 weeks, even with a pinpoint exposure or more exposure, then you will directly do a pulpectomy procedure. Is this clear? Next. This is how class 3 fracture would look like. The patient comes to you and there is a pulp exposed. Class 4 fracture. What is a class 4 fracture? A class 4 fracture is when a tooth comes and it is non-vital. Now, this usually happens, when the patient had a trauma in the past, okay, and it's been time, like it can be either 3 weeks, 4 weeks, or even a year, and then slowly the tooth became non-vital, and then there was a pimple or a cyst formation inside, and the pain started in the gums, or there is pressure on biting, and then the patient comes to you. Sometimes the color has not even changed of the tooth. And you wonder, it looks so nice, there is no problem. What has happened? You take an X-ray and you find a big periapical radiolucency. It can be either in a closed apex or it can happen in an open apex. That's a class 4 fracture. Understood? Now, either case, the tooth is non-vital. When it is non-vital, you have to remove the pulp, be it mature apex or immature apex. You understand? But after removing the pulp, in immature apex, you will either do apexification, that is, either you will put calcium hydroxide and form a barrier, which is going to take like a year and a half, or you can directly put a MTA and then finish off the root canal procedure. Or nowadays there is a new procedure called as revascularization, where what you do is you will numb the tooth, you will place a rubber dam, you will debride the entire tooth structure, you will place some antibiotic medication, call the patient again, then again you will clean that area and you will deliberately put a file and go to the apex and induce bleeding. Now, when you induce bleeding, the canal gets filled up with the blood, and then you will place a cotton and some medicines over it and you will close it. And you will expect that the blood clot that has formed inside is slowly going to form with the help of stem cells. It's going to become a pulp again, and then apexogenesis procedure will happen. uh, Evidence-based dentistry reviews of recent revascularization procedures have shown that sometimes it's successful, sometimes it's not. But as a general dentist, I mean, if you're not confident of it, don't go ahead, because this is a very time consuming procedure and you cannot guarantee success. It may happen it's a complete failure and you will end up with apexification. And how many times the patient will come to you and keep on taking LA, in children especially. So this can be done only in immature apex. It was a closed apex and the patient comes to you with a non-vital tooth, it's a no-brainer. You just remove the pulp, you put calcium hydroxide, heal the lesion inside, and then finish the entire root canal like a normal procedure. That is for class 4 fractures. I hope this is clear so far. Now, what are the types? Now, since we are talking about the apexification procedures or pulpotomy procedures, what are the regenerating bioorganic materials, as people call it nowadays? Calcium hydroxide, MTA. If you would have listened to my presentation about how calcium hydroxide works, I would again repeat, calcium hydroxide is a friend of the pulp. It will do what the pulp wants it to do. It will cheer up like, yay, let me do what you want to do. So if the pulp says, I want to regenerate, calcium hydroxide will like, yes, let me give you all the resources to regenerate. Hence, you use it as a pexogenesis, like to preserve the vitality of the pulp and permanent teeth. You will not do this in a primary tooth if there is a class 3 fracture. If a pulp is exposed, you will not be putting calcium hydroxide because you would cause internal resorption. Because in primary teeth, the pulp wants to resorb. So the calcium hydroxide will help it to resorb more. So calcium hydroxide will only be used in a permanent tooth. MTA you can use in primary and permanent both. And then you have biodentine. I've personally used biodentine from the brand Septodent, and it's been great. Like in 3 or 4 of my cases, amazing. Like I love biodentine. So these are the materials you can use. Take a screenshot of this or write it down. Now let's go to, yeah, these are in detail. You don't want in detail. Now, in case there was a non-vital tooth and the crown is discolored, you can do a walking bleach technique. You know what's a walking bleach technique, right? After root canal, you remove a bit of gutta percha and you put, GIC on top of it. And the entire coronal part of the chamber, you will put a mixture of 10% carbamide peroxide with sodium perborate and seal it. The color of the tooth will lighten because of the bleaching effect and the nascent oxygen effect of the hypochlorite, hydrogen peroxide mixed with sodium perborate with the carbamide peroxide. So it will lighten. That's a walking bleach technique. If still you're not getting the desired result, you can go with acrylic crowns or veneers. Read more about it. It's beyond the scope of this presentation to talk to you about with the bleaching techniques and whatever. Class 5 fracture. What's a class 5 fracture? Class 5, like I said, is the only dental emergency that happens with dentists. That's avulsion, X articulation. Very, very important. Again, essay question. You can write 8 pages over it straight. It will form your main Viva question if you are a pediatric dental specialist in your Viva exam. Okay, let's talk about first the permanent tooth. The most common permanent tooth to be avulsed is maxillary central incisor. So what will happen? The patient comes to you and he will mostly be getting the tooth in the hand or wrapped in a tissue. Smart patient will get it in a bag of milk or a saline. An even smarter patient is going to call you as soon as the injury happens and will ask you, Doctor, my child's tooth came out. And then you will ask, what is the age of the child? You'll be like, Doctor, he's 9 year old. It's the front tooth. And you'll be like, oh my God, do one thing, find the tooth immediately. Where are you? He'll be like, I'm in a park. My child was in a bicycle and he just tripped over and the tooth came out. You'll be like, how is the child first? Doctor, the child is fine. He cried a bit, but there is blood all over. We are scared. What are we supposed to do? Then you calm the patient. It's okay. This happens. Do one thing. Take the tooth. Go to a nearby store. Get some cold milk. Put that tooth in that. Do not touch the tooth from the root surface. Touch it from the crown surface. Put in a bag of milk. Come here as soon as possible. This is what you're going to do. Understood? So this is how you mostly you're going to get a call, or perhaps like most of the times how I get a call, it's from a general dentist. Doctor, I have a 7-year-old patient. He's uncontrollable. He's uncooperative. There is a lot of bleeding happen. I somehow managed to take an X-ray. There is a tooth. I have somehow managed to put the tooth in the socket, but I don't know what else to do now. Or the child is not sitting at all. The parent came to me with the tooth wrapped in a tissue. I have put it in a saline. Doctor, what else can I do? This is how you're going to get the calls. Eversion is one injury or one procedure which nobody will teach you in your dental college, because you cannot intentionally make an accident happen. If you are one of those lucky ones who get a patient on your OPD day or when you're practicing, then you'll get a hang of it, or you will get to observe one of your postgraduate students doing this procedure when you were an intern. Otherwise, pretty much you would not have experience of this. And you are sitting in your clinic, and one fine day a patient will walk in like this, or you get calls like this. And then you'll be like, oh my God, what am I supposed to do? Because you have never done this before. Hence, I've given you the scenarios. It's okay, there is no need to panic. First thing is, when you get an emulsion case, is you instruct the dentist, whoever has called you, or the parent, calm down, make sure the child is okay. Otherwise, take the tooth, put it in a milk, do not put it in water, and just come as soon as possible to the clinic. You go to your reception and you tell them there's an emergency patient coming, and as soon as he comes, we'll make a way for that patient and take him inside. Why? Because of the prognosis of the tooth and the extra oral time. Now, there is something called as an extra oral dry time and extra oral wet time, and the tooth, whether it's closed apex or open apex. These two factors will totally determine how you're going to approach. So you should be very, very clear in your mind, and you should have already filtered this out even before the patient steps inside your room. And you should be prepared with your assistant for the following steps. As soon as the patient comes, first thing is just reconfirm that the child is fine. Take the tooth. If it's in milk, let it be in milk. If it's in saline, just put it in your sterilized cup with the saline water. Just drop the tooth. Or if the patient has come it with wrapped in a tissue, then you put it in a saline again, and you make the child sit on the chair, explain to the parents very calmly that you will be taking an x-ray and you have to numb that area. If required, you will be manipulating the socket, and your aim is to replant that tooth right there and there itself. And the parents, if they are willing to cooperate, take a signature on the consent form that they are willing to cooperate, and hold the child if required, because this is a very delicate emergency procedure and literally the life of the tooth depends upon it. So after doing all this, you go ahead, take an x-ray to see if there is no fracture, and then you also palpate the adjacent teeth to see if they are wobbly, because that would also come under the influence. So after you have done all this, now if the patient has arrived to you within 60 minutes of the injury happened, and the tooth has a, where is that chart? One second, let me go to that chart. I think this is the one. Okay. Now, if the patient has arrived to you within 60 minutes of the evulsion, and the tooth was kept in a medium, that is either saliva or saline or milk, and the tooth is having a closed apex, then you would be straight away, after giving anesthesia, hold the tooth with the crown, not the root. You don't want to touch the periodontal fibers. See, here in avulsion, the entire game is of the periodontal fibers being alive and they reattaching. Because if they are not alive and they don't reattach, then ankylosis will happen, external inflammatory resorption will happen. Ankylosis is the best prognosis, but external replacement resorption is not a good prognosis. It means it's going to eat away the tooth and it's going to fall off. So your best bet is ankylosis happening. Of course, the periodontal ligaments getting reattached and the tooth functioning like nothing ever happened is the ideal scenario, but that I've never seen that happening. Ankylosis, parts of the place will happen, parts PDL will be reattached. So that is your best prognosis. That is what you're aiming for. So you will rinse the tooth with the saline. You will hold the tooth with the crown, not the root, and you will gently replace it in the socket which has been numbed. If the blood clot has formed, you will gently curate it and then you will reimplant. Once you have reimplanted, you're going to put a flexible splint including that tooth and the adjacent teeth. Flexible splint with what? You can either put a composite or you can take orthodontic thin wire and you put it and you put composite over it to put it in place. And that would be there for 2 weeks. Okay, just 2 weeks. This is the treatment. And you will do root canal treatment of that tooth. Yes, you're not going to wait for 7 to 10 days and re-examine. If it's a closed apex, after putting the tooth inside the mouth, you will do root canal. Again, after putting the tooth inside the mouth, you will do root canal if it is less than 60 minutes and it's a closed apex. And you have rinsed it only with saline. Is that clear? Write it down. Next scenario. It's a closed apex. It's more than 60 minutes. Then you would be immersing that tooth because more than 60 minutes, the chance of having the PDL viable is very less. The tooth is inside the medium or just dry. You will rinse that tooth nicely. You will put it in either hypochlorite or you can put in doxycycline, minocycline, sodium fluoride for 15 minutes. You will do root canal treatment of that tooth by holding it in your hand outside the mouth. And then you will reimplant that tooth and put a flexible splint for 2 to 4 weeks. Okay, if it's more than 60 minutes. I am doing here root canal outside the mouth because it's more than 60 minutes. The chances of PDL being viable is very less, so it's no point me reimplanting it and then doing the root canal inside the mouth. I can do root canal outside the mouth because it will be way faster, as I can literally see the GP coming out from the apex. I can burn it at both the ends if required. And then I will reimplant that tooth and give the instructions to the parents and I will splint it. Is that clear? Now, if it's an open apex, do I have something here of the open apex? See here how they are doing the root canal outside the mouth. You see? But this is how you do, you see the GP coming out here, and after you have done the root canal, you're going to reimplant that tooth. Try not to touch the root surface as much as possible. Now, now you have a tooth with open apex. Less than 60 minutes. Okay, again, it's been in a storage media. The child comes to you. Immature apex, the tooth itself is not a problem. The child is a problem because he would be less than 10 years and mostly they are cranky, unconsolable, uncooperative. You will have a great difficulty putting that tooth back. So if it's less than 60 minutes and the tooth is in a medium and they have come to you, you will reimplant that tooth. If the root is contaminated, if it was a play area, then you can just clean it with saline. You can put it in doxycycline just for 5 minutes or minocycline. 5 minutes, not 15 minutes, okay, in an immature tooth because you just want to debride the area. Clean the socket, rinse it only with saline, and then you will reimplant the tooth and again splint it for 2 weeks. And you will wait and watch. You will keep on checking with X-ray and see if the pulp is able to revitalize by forming connections with the body. If not, then you would be doing an apexogenesis procedure or an apexification procedure. You can try either of it, you know. Like immediate, like ultimately, if the apexogenesis is not going to work, then you will go ahead with the apexification procedure. But it's worth a try. You may ask, doctor, why even you are trying to attempt apexogenesis, like just for the sake of it, you know. But if it's not working, then apexification is the final procedure. But you will wait. You will not be directly jumping onto doing root canal. See, in the previous case, when there was a closed apex, depending on the extraoral time, I did root canal after implanting or I did it in my hand and reimplanted. Either ways, the root canal was attempted on that same day at that same time. But in a open apex case, I'm going to wait. I will wait and evaluate 1 month, 3 months, 6 months, like that. At any point, I find external desorption has started happening or my tooth is not responding, I will initiate my apexification procedure. Now, immature apex, more than 60 minutes. I will reimplant and then I would do the apexification procedure right away. So I will remove it, I will fill it with calcium hydroxide straight away. I would like to form a barrier and then finish off the root canal later at a stage. So apexification takes like a year or so. Hopefully by that time the tooth survives and then you are able to do your root canal procedure. You may ask, why not do the root canal procedure right away and then implant? See, you want the barrier to form because you can put GP and you can do the root canal and then try to fix the tooth. But then it's going to be like a very wide seal of the GP at the apex, which you don't want it. So rather, calcium barrier, calcium hydroxide barrier, it will initiate some form of osteodentine barrier kind of there naturally, which would make more sense to do it, and hence the apexification procedure. So this is what avulsion is about. I hope this is very clear. Any case of avulsion, it will only be a flexible splint. Less than 60 minutes, 2 weeks. More than 60 minutes, 2 to 4 weeks. It should not exceed 4 weeks. If after 4 weeks you remove the splint and the tooth is really wobbly, that means the prognosis is really horrible. It may not sustain and you might as well remove the tooth. So these are the kind of splints you see. This is a composite splint. It's a very annoying splint, this big one. This is the best splint. Just take the wire, put it. This is with Rebond, I think. You can also put just a suture like this, but it will be there for like, 2 weeks, which again will look very weird. But then if you have a scenario like this, you have, far away teeth or milk teeth which are wobbly at the age of 7, which is the most commonly scenario. The other tooth has not come out. These two teeth are wobbly and then they would be canine. The splint is not going to last. So then the suture only becomes your option of choice. So then you sometimes have to do this kind of a splint. Titanium trauma splint. No, that's a rebond again. Prognosis will depend how the tooth reacts. Sometimes it can be ankylosis, external replacement resorption, internal replacement resorption. There can be, inflammatory resorption. You have to just keep on evaluating. So don't go to this presentation. It was old guideline where you were placing the tooth and after 14 days doing root canal. No, in a closed apex, you do it right away. Matter finish. So yeah, rest of the other things about storage media, which is the best storage media, ideally it's the socket of the tooth. But parents won't know how to put the tooth properly. Sometimes they can put the tooth other way around, the palatal side facing the labial one, and then it would be another trauma for you to take it out and replace it properly. So if the parents are not aware how to put the tooth back in the socket, which is the best medium, you can ask them to put in milk because that's readily available, or saline. Never ask them to put in water. It's going to damage the perineal tissues. Saliva of the mouth is again a very good storage medium, but then in young children, there is accident of them swallowing the tooth. So you would not be asking them. Hank's balanced solution, it's not available in grocery, right? You cannot just go to grocery and say, give me HBSS solution. So though that is the one of the best extra oral solutions available, unless you happen to be in a hospital, you won't be getting that solution. So again, milk becomes a good choice. So that is what, yeah, emulsion, that's the class 5 fracture was about. Long presentation, right? I'm getting tired talking. But it's fun because I really like trauma, like I said. And I hope you take good things out of this presentation and implement in your practice. And I would be really delighted if after this presentation you get a case anytime in your life and you remembered this presentation, my voice, and whatever I said and implemented and got good success out of it. Do leave me a comment on my YouTube, this thing. I would be delighted. Or leave it on my Instagram. Instagram, I can reply you directly. YouTube, I see it and reply whenever I can. So my Instagram handle is the same, Dr. Garima Khandelwal. And my YouTube, you must be watching this video so you know. And leave your comments as to how you like this presentation or not, like what you could learn, anything extra that you were not taught in school or something is more clearer now. Coming to Ellis class 6 fracture. Root fractures, very important, very, 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 very important. Now they can be either horizontal. Horizontal means like this, or it can be vertical. A vertical root fracture through and through the apex is straight away extraction. It is no brainer. You cannot save a split tooth. Horizontal fractures you can, depending on where it's fractured. So the root of the tooth is divided into zone 1, zone 2, zone 3. Correct? Now, this is a root fracture. See, apical root fractures, now if it is here, that is zone 1, you will accidentally discover it while taking an x-ray of some other tooth. The child or the patient would not be even aware that this has happened. He may give you a history, once upon a time I did hit my tooth, but then nothing happened. Don't touch it. Don't just do anything. Don't wake up a sleeping dragon. The tooth is fine, just let it be like that. But if it's a middle fracture, now it depends how much, it can be a partial fracture, like half of the middle portion is fractured, but the other half would be fine. Like, the fracture line is extending half to the label, but lingually the tooth is still fine. It's like a green stick kind of a fracture. Or it's completely fractured and the coronal fragment is mobile. Now, in that scenario, and if the segment is displaced, like in this scenario, you see the tooth has gone palatally and a crossbite has happened. You have to give LA, you have to digitally position the tooth. If it's coming to you after a week, then you have to get surgically reposition the tooth. And you have to splint it. Now, listen, root fracture will take a semi-rigid splint or a rigid splint, not a flexible splint. And it will always be around 4 weeks, depending on where the fracture is, and it can go up to 4 months. Clear? Avulsion injuries, extrusion injuries, intrusion injuries, all flexible splints. Root fracture and alveolar bone fractures, semi-rigid splint or a rigid splint. I hope this is very, very clear. Now, before I move on to the other parts, middle third fracture around 4 weeks. Cervical third fracture is a very complicated fracture because you have to make sure this entire coronal segment is reattached to the root. Here, the splinting will go on from 2 months to 4 months. That's 8 weeks to 16 weeks. And hopefully the tooth gets reattached. If not, extract that part, extrude the root, do some ortho treatment and fix by post and core, or remove the tooth and give an implant or something else. So I hope this is very, very clear. Apical fracture, do nothing if there are no symptoms. Middle fracture, you can splint and sometimes you have to do root canal, but you will do only till this fracture line and you will splint for 4 weeks, rigid or semi-rigid splint. And if the fracture is here somewhere, 2 months to 4 months, that is 8 weeks to 16 weeks of rigid or semi-rigid. Understood? Very, very clear. Now you come to concussion. I spoke about concussion. Do nothing. It's like a bump. Subluxation. If it's displaced a bit, splint. PDL. Subluxation is a PDL injury, so flexible splint. Extrusive luxation. Again, flexible splint for 2 weeks. Lateral luxation. See, lateral luxation will only happen if it's involved with alveolar fracture. And when there is an alveolar fracture, 4 weeks of flexible, rigid splinting or semi-rigid splinting. Intrusion. Intrusion. Let's talk about intrusion. Let's go to intrusion. I will talk about the primary teeth also. Let me just finish with the permanent teeth first. Intrusion. Okay. Now in intrusion, see how this is how the teeth have intruded. If it's less than 3 mm of intrusion, means you can literally see. So if the intrusion has happened at this level, okay, forget this picture. If the intrusion has happened at this level, you do nothing. You just let the tooth re-erupt. And if in 3 months' time it is not re-erupting, then you will orthodontically make it erupt. And you do nothing. Nothing means to the pulp. You do nothing. You don't even splint it. You do nothing. Just leave it if it's less than 3 mm. But if the tooth was intruded more than 7 mm, means only the tip of the tooth was visible here and the rest of the tooth is inside. Means what has happened is the apical portion of the alveolar bone has fractured and the tooth has gone inside. 101% the blood supply has been severed in this scenario. In that case, you have to give LA, you have to surgically drag the tooth down and you have to splint it and you have to do a root canal treatment also. Now, if it's a closed apex, 100% you have to do a root canal treatment right there and there. If it's an open apex, you can choose to wait for like 2 weeks or so, and eventually you'll have to do the apexification procedure if you find the tooth is not responding properly. So this is the management of intrusion in a permanent tooth. Clear? Class 8 fracture. What is an 8 fracture? It's fracture of the crown and mass. So the entire crown portion has been fractured. Now depending on where is the fracture line, you can do root canal, do a post and core and then fix it with a crown, like what has been done here. Or if it's too bad, you just extract the tooth. There is no other treatment possible. If you can save the tooth, it's good and great. I will show you one of my cases in the primary tooth like this. But right now, let's just finish off with the permanent part of the classification. Class 9 fracture. What is class 9 fracture? Class 9 fracture is all the classifications that we have discussed 1, 2, 3, 4, 5, 6, 7, 8 happening in primary tooth. So if I tell you the primary tooth has come with the fracture of the enamel, what is the classification in Ellis? It's class 9. It's come with the fracture of enamel and dentine, again class 9 fracture. It's come with the fracture of enamel dentine pulp or non-vital or avulsed or root fracture or any kind of a thing in a primary tooth. Everything falls under class 9 fracture. Okay, so if I just say there was a class 9 fracture, you really don't know what type of fracture has happened to the primary tooth. Hence a new classification, Garcia-Godoy classification for the primary teeth, which is exactly the same as Ellis's class 1 and class 1 to 8 fractures, but it's a Garcia-Godoy classification for primary teeth. Now let's talk about primary teeth. Well, primary teeth, let's go back. And let's just imagine all this were primary teeth now, okay? So we come to Ellis class 1 fracture, or let me just go back to that good picture that I had. Where was it? Yeah, this picture. So primary tooth, patient comes, primary tooth means less than 7, okay? The tooth had nothing, so nothing has to be done. Now, Enamel fracture, you will just do enameloplasty or you will put a resin cement. Crown root fracture, I'll show you one case. This is an uncomplicated fracture. If this has happened, if you can smoothen that area, great. Otherwise, just extract the tooth. If you can smoothen the area, excellent. If you can rebuild the area, excellent. But if the child is really small, not listening, and it's a very sharp cut, extract. It's okay. Or smoothen and put a composite. Concussion has happened, do nothing. Subluxation has happened. Too much of displacement and subluxation, a bit of extrusion, you can leave it like that. You don't have to do anything. But if it's like really too much extruded, extract. Do not try to digitally reposition it back because you may injure the permanent tooth part. Intrusion is very important. See, if the intrusion happened in this direction, now imagine there is a permanent tooth bud out here. Okay. Now, if the intrusion happened in a direction where the crown of the tooth is pushed palatally and the root has been displaced labially, you can leave that intrusion as it is because the tooth is pushed inside and you see the crown here somewhere and the root is here. You can't see the root, but based on the position of the crown, you can make out the root is here. It is not disturbing the permanent tooth part. So you can leave it as it is and the tooth would re-erupt. Okay, and I have seen such intrusion cases, the tooth re-erupting very nicely and then falling out and the new tooth also coming very nicely. But if the tooth has intruded in this direction, that means the crown of the tooth is labial. You see the crown is protruding from the lip. That means for sure the root is in this direction. Then it is impinging on the permanent tooth bud. Definitely some sort of trauma or damage will start happening or may have even happened, causing a Turner's tooth or some displacement of the permanent tooth, some dilaceration or something, or will happen eventually. You will extract this tooth. So depending where it is intruded, where the root has gone, if the root has gone labially, you do nothing. If the root has got palatally, you remove this tooth. Understood? Lateral luxation you remove because it's really difficult to digitally position and splint in young children, 3 years. They are not going to sit. I have extracted such teeth. 1 or 2 mm of extrusion, leave it. Too much of extrusion, remove. Root fracture. This kind of root fracture, you tell the parent if the tooth is wobbly that you are going to extract it and you're going to leave this piece inside if you cannot access it because the permanent tooth bud is here. And it will eventually fall off when the new tooth is trying to erupt because this piece is not infected. It's just fractured and which is all right. Alveolar fracture, you have to splint the entire segment and you have to refer to the oral maxillofacial surgeon. Avulsion. Now, I have seen some people trying to reimplant the avulsed primary tooth. I will advise against it because you may accidentally damage the new tooth. So, it's alright not to reimplant the avulsed primary tooth. Understood? Coming to class 3 fracture of the primary tooth. When the pulp is exposed, you will never do a pulpotomy in an anterior tooth. You will always do a full pulpectomy in an anterior tooth because there is no convergence at the CEJ junction. You do not know till what level you are going to remove the pulp in the primary tooth to do a pulpotomy. You can do that in a molar, but you cannot do in a primary tooth. So there is nothing called as pulpotomy of a primary tooth in a class 3 fracture. You will remove the entire pulp no matter what time of exposure, no matter how much the exposure. The pulp is exposed, it's exposed because you cannot put calcium hydroxide. You understand? Why? Because it will cause resorption. So you remove the pulp, you do a proper pulpectomy because anyways the apex is closed. And then you fix that situation. Now in case of a complicated crown root fracture, let me show you one of my own case. You see this? This was a 2-year-old child when they had come. Not even two, actually. The canines have also not erupted. This is how they came, and this is how the X-ray was. You have a look at this. The tooth was fractured at two different levels. This was a full on fracture. You see this? The segments have only separated, and this pulp tissue and the gum tissue is kind of hanging on the segments. It was a very complicated case, but the parents were really keen to save the tooth. And this vertical fracture line was extending till this, like it was a little below the gums and inside the bone, but it wasn't a complete fracture. You see, it was just a partial fracture, but this area was completely fractured. So what we did, we put this child under full anesthesia, and I removed this segment. Now I was left with this part and a little bit of fracture of the enamel, dentine, pulp, and the root. So I did full pulpectomy of this tooth, and then I've put my zinc oxide eugenol as an obturating cement, and I put a post here, cemented it with GIC. I glued up this segment together, and I put a zirconia crown, and this is after 2 weeks. Beautiful, right? So complicated crown root fractures can be saved only if it's extending till this. Now, had this fracture line been extending till this point, I would have extracted the tooth right away. Understood? Clean and clear. I'll show you one more case of, it's not a fracture, but it's kind of a class 3 involvement in an 18-month-old child. Yeah, here. You see this? This is not a fracture, but because of the caries, this was the entire pulp which was exposed. And these two were like absolute non-vital, and this was also going for root canal. The child came crying and drooling, can't eat because the pulp is very sensitive. So class C fracture can come to you like this. And then you do root canal and you save all four of them. So this is how it is. I hope now all the classification is very, very clear and you're more confident of doing this. I know it's a lot to take in, and I want you to make sure that any kind of trauma comes to you, you follow it up after a month, 3 months, 6 months, 12 months, and eventually how the permanent tooth comes out. If the trauma was to the primary, if it's a permanent tooth, you can follow up on a yearly basis after the 1 month, after the 1 year follow up, sorry. So this was the entire big dental trauma. I hope you people like it. Leave me your comments to know how you felt about it. And hopefully now you can attempt all questions very, very correctly after listening to this classification. Thank you so much.